Greetings from Kenya. Thank you for joining us as we explore the challenges and opportunities for delivery of PrEP for women. And my name is Faith Kiruthi from Nairobi Metropolitan Services, the Health Sector Directorate. And I will be leading the session today. Joining me in this discussion is we have two panelists. We have Dr. Rivet Amico from University of Michigan and Mercy Kamau working for JPEGO Kenya office. Welcome Mercy and Dr. Rivet for this conversation, and we're looking forward to hearing what you have for us. To start us off, I would really want to know how it has been implementing PrEP in your various countries for women.
Thank you, Faith. In Kenya, I happen to have worked for the largest project that was implementing PrEP from 2016, that is Jilinde, which is funded by Bill and Melinda Gates. Our main focus for delivery of PrEP were female sex workers, adolescent girls and young women, and men who have sex with men. For today, I'm just going to share the experiences we learned from delivering PrEP for women. And what we learned from the project, among the people we have enrolled, 75% were women, because currently we have a total of 36,180 clients enrolled on PrEP and 27,233 are women. So among these women, the larger proportion was female sex workers who are taking up PrEP, followed by adolescent girls and young women, and then women from general population, and then discordant couples. Accessing PrEP from dropping centers, especially where they felt that the service delivery for PrEP was more friendly, and they were being their needs were taken into consideration, and there was no judgmental attitude towards them, bearing in mind their heightened risk for HIV acquisition. Only a few percentage of people we delivered PrEP to received services from the private facility. So when these women come to access PrEP, inconsistent use of condom was the main reason why they were coming for PrEP, and also having sexual partners of unknown HIV status. So majority of women, the huge number of women, around 70%, had those main reasons. Like inconsistent use of condom was 46%, and those who are having sex with women with partners of unknown status were 35%. So we realized those are the two main reasons why women were coming to access PrEP. And when we look at the continuation was better for women compared to men. And we realized like mostly continuation for men, for women was going above 40%, but for men, it remained below around 30%, especially at month 1. And when we go to month 3 continuation, you realize for men is even far much lower, but for women, it remained at around 25 to 30%. So women have proven to continue or to adhere better to PrEP compared to men. So basically, that is how we have managed to implement PrEP, and we have realized that women can generally take up PrEP when they are well mobilized to come for services.
Thank you for that. Now it sounds a very interesting way, and also something else. What have you learned during the implementations? What are the key lessons that you learned during the implementation?
Okay, one of the key things we have learned as a project is like use of human-centered design in developing strategies and interventions for women was very key. Because during the entire Jilinde project, we utilized human-centered design just to understand women, what they need, how do we deliver this PrEP to them, and that is why we found they're coming in large numbers in terms of accessing PrEP. It was very key in terms of strategy. The other thing we learned, it is important to deliver PrEP outside clinical setting, because clinical setting was very limiting in terms of women accessing. You remember these are non-sick women or they are healthy women who are supposed to get a medicine for prevention. So when it is placed in a clinical setting, it was creating a lot of barrier. And therefore, when PrEP is delivered probably in a more easier way, maybe community delivery model or differentiated care model at the community level, it may make it easier for women to access PrEP. Then for adolescent girls and young women, we also learned that it is important to form a supportive mechanism for PrEP delivery among this population, especially for those who are in school. They are at heightened risk of acquiring HIV/AIDS, but they cannot access PrEP because they are in school. So there is need to see how to access these young women, especially those who are in school. Then the other area we felt it is important for implementation is integration of PrEP in all service delivery areas, especially in the antenatal and postnatal clinics where women are coming for maternal and child health services, because we realized PrEP can be a very important tool when it comes to elimination of maternal to child health, maternal to child HIV transmission. So it is very important we have PrEP integrated in other services area, especially the antenatal and postnatal clinics. We also realize that when it comes to messaging for PrEP, it is important that the message for PrEP is packaged as an empowering tool. Because when we were implementing, we realized that when you focus on telling women you take PrEP so that you don't acquire HIV, the message does not sync for them. Or take PrEP because you are at higher risk. That message does not sync. But when you position PrEP as an empowering tool for women, it was becoming much better and acceptability was high. So that was another key lesson that we learned. Then we also realize social network among women are very important and they play a key role in influencing decisions of women. And therefore, when doing demand creation or awareness creation for PrEP, it is important to ride on the existing platform for women where they socially meet or where they socially network. We also learned like community-based approaches really promote acceptance of PrEP and minimize stigma for PrEP. And therefore, it is easy when you use these community-based approaches and social networks, it is very easy to make PrEP a social norm. Then we also realized for young women, especially adolescent girls and those who are below 24 years, they are really in digital world. So it is very important to utilize the digital platform to reach out to these young women. And it is a key service. It can be a very key delivery model for, especially for messages for young women and other women who are using social media platforms. So I think mainly those are the key lessons learned we have learned from Jilinde project.
Thank you. Wow, very insightful. Now, of course, in every program, there are challenges that are faced. Maybe you can just share a bit of some of the challenges you experienced during the implementation process.
Okay, there are quite a number of challenges. Bearing in mind, PrEP was a new tool for HIV prevention. It came with its fair share of challenges, and one of them we realized among women was gender and power dynamics in delivery of PrEP for women. We realized that most women were not empowered to take that bottle of PrEP and go with it home because they feared their spouses. They feared intimate partner violence because of carrying that bottle of PrEP, because they didn't want to show to show their spouses or their partners they are using something for HIV prevention. So there were a lot of dynamics, and you realize the bottle for PrEP really rattles when it is put even in a lady's handbag. It rattles a lot. So you realize that most of these women were fearing that bottle because they would say their partner might know they are carrying something in their bag. And that was really disempowering for women. Most of them could not even carry PrEP home. So that was the downside of delivery of PrEP for women. Then again, PrEP required discussion around sex and sexuality. And in our African culture, most women are not empowered to discuss sex and sexuality because it's more of a taboo for us. And therefore, you realize that PrEP required to have in-depth understanding of a person's sexuality in order to measure their risk so that the provider can be able to provide PrEP for them if they are at risk of acquiring HIV. So this discussion, for most women, it was a bit challenging to have that discussion with the service provider. Then the other challenge was PrEP was delivered mainly in the HIV clinic referred to comprehensive care centers. So women were fearing to be associated with HIV. And whenever they wanted to go for PrEP and they realized they have to get their refills or they have to be initiated at the comprehensive care centers, most women shied off and they would go away because that place where PrEP is delivered was not very friendly for them. The other thing is stigmatization of PrEP as for people who are promiscuous. And mostly it was labeled like a tool for female sex workers. And you realize most women would shy away to go and take PrEP because they did not want people to mistake them as being female sex workers. So therefore, that also brought a lot of limitations when it came to women accessing PrEP. Then, of course, adherence and continuation was a challenge all over. And I think this cuts across all population. Though women continuation was a bit better than that one of men, but still it had a lot of gap because it was around 40 something percent, at most 50%. So you realize when you have a continuation of 50%, prevention is not guaranteed. So that one remains a challenge. Then the other thing is the time-consuming nature of PrEP delivery to women. You realize there are a lot of protocols that have to be followed for women to access PrEP. They have to be tested first for HIV. Then after testing, they have to be screened for risk. After screening, the service provider have to do the eligibility criteria. So there were a lot of protocol. And you remember, this woman is not sick. So they feel like this is too much time wasted, or I'm being subjected to too much protocols before I access this PrEP. So they felt it was somehow a burdensome kind of HIV prevention. Like with condom, you just go collect the condom and you go use. But now for PrEP, it required a lot of protocols for you to, before you are given the PrEP or before you are initiated on PrEP. So that one became really a barrier for access to PrEP. Then the other challenge we realized, the location of PrEP at the comprehensive care center limited so many women who are coming for other services into the facility to access PrEP. If PrEP is integrated in all other service areas like family planning room, the postnatal care room, the antenatal care room, you realize more women would have known more about PrEP, and also the uptake would have been higher probably than that. So we realize that integration is lacking and it needs to be embraced. I think basically those were the major challenges for women accessing PrEP.
Oh, thank you so much. That was awesome. Now, from all that, what are some of the opportunities that you feel any country would tap on in terms of service delivery for women, for PrEP delivery for women?
Okay, to start with, women have not benefited fully from HIV prevention options that are available. And this is really a big challenge, and we need to look into the opportunities that are existing to ensure that women access PrEP. One of the opportunity is the diversification of service delivery model. PrEP, because it's for non-sick people, we can diversify the way it is being delivered, either through pharmacy, it can be delivered through community-based distributors, so that we have PrEP accessible easily rather than putting it into a clinical setting. You just need to have trained personnel who can deliver PrEP quickly to the people or to the women who are in need of PrEP. Then we also feel there is an opportunity to reach out to adolescent girls and young women, because if you look at our country now, and even in sub-Saharan Africa, majority of the new infections are happening among adolescent girls and young women who are below 24 years. Sorry. So we realize this is an opportunity that is untapped, and we need to work around strategies and innovation to reach out to this population. Then I've mentioned about this integration of PrEP in all service delivery areas so that it doesn't look like a HIV, it's only related to HIV. If it is integrated all through, even it will be normalized, and then stigma will go down, and then women will be able to access PrEP. Then the other opportunity we have is to design messages that are empowering women. I know Jilinda tried to design these messages, but they cannot apply in all contexts. It need to be contextualized based on different population, different communities, and therefore every community needs to design messages that are empowering women, and that is an opportunity. And also, these messages should focus on making PrEP a social norm so that acceptability go high and everybody feels like PrEP is something that we need as part of our prevention tool. Then the other opportunity we realize, there are so many social networks that exist among women. Like in Kenya, people are very social. You'll find they join groups, they join other chamas, and all these opportunities are there for us to deliver these messages. Right now, if you look at the digital platforms, you realize there are a lot of groups like WhatsApp group. They are happening. People are interacting through Facebook and all that. They have their friends. So we can utilize these social network platforms to ensure PrEP is well integrated. So I basically think those are the main opportunities that we realized under the project.
Real pleasure to be able to be part of this panel and to provide some brief responses to the questions about exploring challenges and opportunities for delivering PrEP in women. Great. So in response to some of the questions that we got, I brought together a few slides just to be able to organize some of the comments back. I have no conflicts of interest to report. Not over. So cisgendered women in the US, about 23% of the 1.1 million people living with HIV in the US are cisgendered women. Rates of new infections have declined 23% since 2010, which is great. But in 2018, women still accounted for 1 in 5 new HIV diagnoses. 85% report heterosexual sex as route of acquisition. 15% reported injection drug use related route of acquisition. And even though Black African-American women make up 13% of the US population, they accounted for 60% of new cases of HIV in 2017. So HIV for cisgendered women in the US is still a very pressing issue, particularly for Black and African-American women. So keeping that in mind, when we think about how it has been implementing PrEP in your country for women, by and large, I would say it's been slow in terms of start, and we're also, because of that, looking at low rates of uptake. So in 2012, PrEP uptake was low among cisgendered women. In 2017, it went up 12-fold among women, but 93% of PrEP users in 2016 were men. PrEP starts and use continue to be dominated by white males in the northeastern United States. So women, even though they're 19% of all new HIV infections, still only 7%, they make up only 7% of PrEP users in the US. So 28,000 women have been estimated to have started PrEP, but that's only an estimated 2% of all women with indications for it. I think in part that has to do with a lack of inclusion among cisgendered women, and it's really lagged behind that of other groups, which I'll talk about more in a moment. And even though I'm focused on cisgender women, I do want to note that the situation for trans people is really quite similar, with only 3% uptake of PrEP among those who would have indications for it. So we're definitely getting better. The last several years has seen massive push towards inclusion. And here are several examples that you can see from different states around the US that have really made bold efforts to include cisgendered women in their campaigns to try to raise PrEP awareness, as well as providing PrEP services. But it's important to note that women were absent from the Descovy trials. They continue to be poorly represented in the literature. So there's still a lot of ground to cover when it comes to implementing PrEP in our country among women. Okay, but women are still absent from they were absent from the Descovy trials, which is noteworthy. They're poorly represented in the literature still, and we still have a lot of ground to cover. So it's been challenging overall in terms of implementing PrEP among women in our country, in the US, but there's been substantial progress and we have a long way to go. And that has to do with the other questions that were posed of us. One is, what are the key lessons learned? And in thinking about that, there's a lot of different directions or avenues that you might want to unpack, and I'm just going to focus on a few. One thing that seems clear is that once informed about PrEP, women do seem to be interested in it. And factors influencing women in terms of that decision have included cost, social norms, provider support for it, and ease of accessing services. Also perceived risk, and the fact that perceived risk is really embedded in high exposure risk environments, which I'll return to in a moment. The other key lesson is that we really need to be cautious and watch for continuity with PrEP and prepare for it. So some estimates show that PrEP continuity is about 60% at 3 months and 38% at 6 months. In the AGIS project, among that sample of women, about 18% had consistent drug detection over a 48-week period. And that's not just for women. We know that continuity with PrEP is an issue overall. But what I want to say a key lesson is it really behooves us to think about providing PrEP in the context of comprehensive prevention services. Because if people are starting and stopping PrEP, they may still be interested in other services that might be available. And so if you can offer PrEP in a service or in a program that has multiple prevention opportunities and options, it might prepare us better to be able to work with people who are starting, but then for whatever reason decide that PrEP is not for them. Another key lesson is location, location, location. So to the extent that we can offer PrEP where women go, that will be an advantage. And that includes family planning clinics or existing programs. We know that many women use regularly family planning clinics. And in fact, in the United States, there's a sizable portion of women that is the only medical care that they seek. So being able to offer PrEP where people are already going can be extremely meaningful and important. Also, there's many ongoing projects that look at co-locating PrEP services. And you can see on the screen a few of these, but Project She, other projects that are hosted within needle exchange programs or syringe exchange programs. And there's several projects that are going on with family planning, as well as opportunities to engage women where they are already going. The other thing to keep in mind is context, context, context. So offer PrEP with sensitivity to context and include those kinds of services because they may be of highest relevance to the people that are seeking PrEP. We know that poverty, lack of access to healthcare, racial segregation, incarceration, food insecurity, unstable housing, and intimate partner violence and trauma are all very real factors that women have to negotiate in their lives as they are also considering PrEP and HIV prevention. I think that's something to spend a particular amount of time with or spend some attention to, because we know from AIDS View and the work that's done looking at the geographic discrepancies in terms of where PrEP is provided, that states that don't have Medicaid expansion, states that have high levels of poverty and lack of access to healthcare are also the states where PrEP uptake is particularly low. So being able to address these factors becomes critically important when we're thinking about providing PrEP or increasing access, increasing uptake among women. And we're still learning, right? There's many calls to pay attention to women in PrEP, but there's limited data still available. There's an abstract presented at this conference by Jessica Crawford that notes that the recent literature review trying to summarize PrEP adherence to open label trials identified very low representation of cisgendered women in the findings in the samples. And there's more to come. So looking at ct.gov, you can see that 178 studies involving women and PrEP in the US are listed as either recently completed or ongoing. 70 are ongoing. So we know that very soon we will have a lot more literature to be able to look at to help us to understand decision-making around PrEP for women, as well as uptake and adherence over time. So I want to shift focus to the challenges that were experienced during implementation. Obviously, there's a number of challenges, but again, that women lag far behind in terms of awareness and uptake, and largely that can be, at least in part, attributed to non-inclusivity. And the non-inclusivity of women in early attempts to, market PrEP, to make people aware of PrEP, to have PrEP be accessible to people, really only recently has made efforts to include cisgendered women in those. So we've had to play some catch up on that. And not only that, but because inclusion was not there initially, it was not uncommon for women to feel as though PrEP was effective for others, but not really geared towards them. So we've had to undo attitudes and beliefs, and that has created, I think, a greater lag and challenge. We need community-driven approaches because we need to recognize that one size will not and does not fit all. So the needs that one group of women may have in one geographic location may vary tremendously from another. We also know that the social structural factors are prevention issues. The list of factors that we just talked about are not secondary issues. They are the issues that women are dealing with as they also deal with prevention. So they need to be incorporated in our efforts. Continuity of use, we mentioned, it's an issue across all groups, and we need to better prepare for that. And we need investment in women. From AVAC, you can see that this is a distribution of total dollars invested in women. So the total PrEP investment being 100%, 25% of that is women focused. And you can see the distribution there, but by and large, it is a disproportionately small amount of funds are really being allocated towards better preparing for and better getting PrEP out to women. There's a lot of opportunities that remain. So one opportunity, and I think I've said this several times, is inclusion. So inclusion in discovery efforts, in studies, in demonstration projects and implementation efforts, in marketing specifically, and inclusion of women in generating programs as well as generating solutions. The location for service delivery and comprehensive services is another great avenue for expansion. And also mapping and mitigating those structural factors that limit women's growth opportunities overall, and in particular in terms of PrEP. So I'd like to thank you for your time and attention. Thanks.
Wow, thank you. Thank you so much, ladies. That was fantastic. It was a very insightful discussion and very valuable that our viewers, our listeners have actually gotten the message and will actually benefit from the discussion that we have had today. Thank you so much and stay safe. Thank you.